You're watching Champions of Care, brought to you by Oakwood Healthcare. We cover a variety of health topics to make you informed to stay healthy and to be a more informed patient. The topic today is women's health issues, and in this segment, we're going to talk about female incontinence. Sometimes it's called stress incontinence. Sometimes it's called urinary incontinence. We have an expert with us in the studio, and I'd like to introduce you to him. Dr. Salil Khandwala, we're so happy to have you.
Thank you for having me.
You're a urogynecologist. You practice at Oakwood Healthcare and have offices in Dearborn, and you're going to teach us about this topic.
I'll be happy to. What
is urinary incontinence? Let's start right there.
Urinary incontinence is the accidental leakage of urine that happens beyond a woman's control. You know, there are two major types of urinary incontinence. One is called urge incontinence or overactive bladder, which is that gotta go feeling. So before she actually can make it to the bathroom, it's almost coming out with significant urgency. The other, or the more common type of urinary incontinence, is something as what you refer to, stress urinary incontinence or effort incontinence. That is leakage that happens with activities such as coughing, laughing, sneezing, or any exertional activity. It's very common. In fact, a large number of women suffer from this problem.
Well, I figured it was a large number because I'm seeing these commercials for panty liners or special disposable underwear or fancy diapers that aren't, necessarily for senior citizens. So it is very common.
1 in 4, if not 1 in 3 women suffer from this problem. Can you imagine? That's how common it is.
Is it just women who've had a baby?
Not necessarily. We've had a lot of women who have not had children, never been pregnant. They could have this problem. So yes, it is true that women who have had a child, especially vaginally, may have a higher likelihood of getting incontinence, but at the same time, that does not exclude the others. It just depends upon a female anatomy. So,
well, let's tell us about the anatomy and what's going on in there that isn't working right.
Yes, if you look at a typical female anatomy, just to get you an orientation here, this is the head, the feet, front, and back. So you're looking at a woman standing up. Here, right behind the front bone, you see the bladder, and below the bladder is the urethra. Now, what stands out in a female anatomy is that the urethra is just a short, straight tube to the outside. So that's this particular tube. In a male, it's a 15-centimeter long tube, and then you have this uterus muscle around the urethra as the prostate. So for men to leak urine is almost unheard of. They have a different problem. Females, because they have a shorter urethra and a straighter urethra, they're more likely to leak urine, and that is what predisposes to them. So if you were to look in the next slide, what typically happens in a woman with stress incontinence, so here the dotted line is where the bladder is at rest, along with the urethra. Now, when she strains down, the bladder gets pushed back. Now, normally the tissues between the bladder and the vagina might hold up and prevent this backward movement of this urethra. However, if the tissues have weakened, it'll allow that urethra to fall back. Then what happens is, as this urethra moves backwards, it sort of loses its control, and therefore one leaks urine.
Now, this is a very interesting female condition, because we're the ones diagnosing it, aren't we? We're the ones who notice, whoa, something's not right here.
Absolutely. So when it comes to the diagnosis, or what typical test do you have to use, it's simple. It's history. It's what the patient tells us. So if she says that I'm leaking when I cough or sneeze or jump, so it's obvious that right there is this particular condition. So you don't really have to do tremendous million-dollar tests to confirm this particular diagnosis.
All right. So I've discovered this as a patient, and I tell my physician, or maybe I tell a specialist like you, a urogynecologist. So then what can you do for me?
Well, there's a lot that can be done. First of all, something simple. It could be just that caffeine intake. Now, we do what is called bladder voiding diaries and see how much is this woman drinking. And if she's drinking a lot of water as a modality of losing weight, or if she is drinking caffeine, that can cause urgency at the same time, increase urine production. So simple things like that. And sometimes you have patients like in the hospital, nurses who work shifts, they don't go to the bathroom for 6-7 hours. And then they have a bladder which is filled up like a tank, and then they cough and they may leak urine. So here it's simple thing, like just go to the bathroom more often rather than wait too long. If that they've already been doing, and most of these patients have been doing that, then two classic treatment options, one is non-surgical and the other is surgical. Now, even if I say surgical, it's more of a procedure than a true surgery. The non-surgical is where we do something called physical therapy of the pelvic floor muscles with electrical stimulation. That is very different from the Kegel exercises. Like many of our patients will come and say, oh, you know, I've done Kegel exercises up to, you know, for so many years, kingdom come, and nothing has happened, you know. I still have this problem. And then when you actually examine them, they have not been doing the right muscles. They may have great abs, but that doesn't help. You know, you need the pelvic muscles to strengthen. And that's exactly what we do. There's a little probe that sits in the vagina that picks up the impulses from the muscles. So on a graph, we can actually identify how well they're squeezing their muscles. And then we go ahead and stimulate those muscles to strengthen and contract. So the very muscles of the pelvic floor near the vagina, which are so important to maintain integrity of the pelvic floor, are therefore strengthened by this particular therapy.
So I can strengthen my muscles. What else can I do?
The alternative is to do this procedure, what we call a sling procedure, which is putting a little tiny strap under the urethra as it's seen in this case. So you can see this is a sling, and that's all that stays in. This particular device obviously comes out, and in this case depicting the urethra as this pen. So normally if this were to be the urethra, and right now it's just freely falling down because there's nothing supporting it, that backstop has weakened. Now suddenly you put a strap under it to support it, it finds its new backstop, and that protects the urethra and therefore retains continence.
That looks almost like a piece of fabric. Is it pliable and soft?
It's in fact a material made of proline, which is a thread that's used for decades in surgery. And that little tiny, it's only about 8 centimeters long and just 1 centimeter in width. That's how tiny this is. It in fact can sit in the palm of your hand. That's how tiny this mesh is.
Well, that's amazing.
And the good thing is it can be done entirely under local anesthesia. And it involves just a very small 1 centimeter incision inside the urethra, as long as a fingernail, and that's it. And from there, there are no exit incisions, nothing comes out. It's just this little sling supporting it. And the main goal of doing this under local anesthesia is that you can have the patient cough. So first she coughs, then she leaks right in front of you. You put the strap in, she may still continue to leak until you make it tight enough, and then she's not leaking anymore. So right there, almost instantaneously.
Perfect it right there.
Exactly.
Well, it's great to have you telling how this procedure works, but we're also blessed to have one of your patients, Dr. Khandwala, who was willing to share her story about the sling and her lifestyle change. Let's take a look at what she had to say.
My name is Maureen DiGiacomo. I live in Flat Rock. I did notice incontinence issues probably about 10 years ago or so, but they did get worse as I lost weight and started to work out. The bladder would leak a lot more. I decided to lose weight for health reasons and to make myself look and feel better. Well, I began coming up here to the community center in Flat Rock. I walked on the track and stuff like that, and then I decided I could do this harder stuff, more running and using the Stairmaster, lifting the weights. And one day I just decided to go in there and try it, and I kind of got hooked on it. Because of the exercising, jumping, the bouncing, the running, stuff like that, my bladder would leak. I'd be using 4 or 5 incontinence pads a day. Oh, I have gone home from here. I've told my husband I have to go because my clothes are actually getting wet. It's leaked through the pads. And it is an embarrassing thing for women. You know, you can't walk, run, your bladder's leaking, you're wearing pads. And it's very embarrassing, but there are options out there for us. And I spoke with Dr. Khandwala. He told me about his procedure. Because of the testing that I had done, Dr. Khandwala advised that I have this transvaginal taping, which is a TVT. So it's just a small mesh that he inserts. And he showed us that, and then that's what he recommended. Procedure was very easy. I went to Oakwood Hospital in Dearborn. It was probably an hour, hour and a half procedure. They give you some sedation, he puts it in, and you go home. I was able to run my first 5K at the Turkey Trot in Detroit in November that same year. It's a woman's issue, and there are ways to fix this. There's no reason to live like this. I can be able to run, walk, do whatever I want without having any bladder incontinence at all. Dr. Khandwala gave me my life back.
Dr. Khandwala, if this procedure is so simple and minimally invasive and I'm home the same day, why don't more women take advantage of it?
You know, that's the sad part of this thing. The main reason is because it's considered to be an embarrassing situation. And then that is further added on by the fact that they feel that they're alone and isolated. So nobody else has this problem. They're least aware that in fact 1 in 3 women have this problem. Once they find that out, and once they know that something can be done so minimally invasive for this problem, automatically they want something to be done. In fact, invariably when patients come to the office and they have this problem which has been ongoing for decades, when we tell them the solution, they want it yesterday.
I'm sure they do. Well, our patients can find out more about you. Our viewers, not yet patients, can find out more about you and find out more about Oakwood.org and Oakwood Healthcare by going to Oakwood.org. And you are accepting new patients, is
Yes.
that correct? And you have offices in Dearborn, so if someone wants to call, they can call 543-WELL and get connected with you. Thank you so much for being with us today and teaching us about this topic.
Thank you for having me.
Thank you so much. And I also want to thank our guests, Dr. Karen Plymell and Dr. Charles Cash. For more information on a variety of women's health issues, please visit Oakwood.org. And thank you so much for tuning in today to Champions of Care. We'll see you next time.